So I'm Dr. Manish Mahendra. I'm working as a senior consultant at Khairabad Eye Hospital, Kanpur, and I'm a cataract and refractive surgeon. So I'll be talking on traumatic aerodialysis repair, modified techniques. Now, we all know that aerodialysis is basically an avulsion of the iris from its natural insertion on the ciliary body that might be accidental or iatrogenic in nature. So whenever we get these cases of trauma, it's very important to not only look at the aerodialysis, but also see the the zonules, because underneath these aerodialysis, the zonules can also break. So before you do a surgery, a thorough pre-operative evaluation is a must, and you should always analyze your case and see whether you're dealing with along with the dialysis, you're also dealing with another dialysis, that is a zonular dialysis. And if it is so, then you have to plan your surgery accordingly and use CTR rings or other instruments. Again, timing is very important. Whenever we are dealing with these traumatic cases, we know that we will have a lot of inflammation. Patient will come to you with hyphema, with severe reaction, inflammation. So it's important when to plan your surgery. So you have to treat the eye, make it quiet, and once the eye gets quiescent, then only you need to operate. So the timing is important. Another issue is that you should not wait too long for the surgery, because if you wait too long, then these tissues, they become fibrotic, they become fragile, and then to repair these aerodialysis becomes very difficult. So it should neither be very late, nor it should be early. So I'll be demonstrating my surgical technique here. Now, I'll be showing you a handbag technique. Now, basically what we do here is we make a side put incision, and you use a ninoproline suture, a double arm ninoproline suture. And as you can see here, through this paracentesis, we pass the one end of a ninoproline suture, and we take a bite in the peripheral iris, and then also create a scleral tunnel about 2 millimeters away from the damaged iris, and then externalize this needle. And then after we externalize this needle, then we take the other end of the double arm needle, and then with the same method we go and then externalize it through the sclera, and then we pull the sutures and stretch the iris, as you can see here. And once we stretch the iris, then we get a relatively round pupil, and then we tie the knot and bury it. So I'm going to demonstrate you here. Now, this was a traumatic cataract with an aerodialysis. So we make a stab incision, and first of all, I use some iris hooks just to stretch the iris and get a more wider and better view. These iris hooks are very good when you're dealing with small people, especially. So I did my capsulorhexis, and this was followed by insertion of the CTR. Now, before this surgery, I saw that there was a small zonular dialysis also, so I implanted a CTR here. And then, as you can see, the cataract is pretty soft, so I did a phaco aspiration here, and then this was followed by an automated irrigation and aspiration, and then the implantation of the intraocular lens. Now, then we did, you can see here the aerodialysis, then we did a conjunctival peritomy. I did a wet white cautery, and then made 2 scleral incisions about 2 millimeters away from the sclera, parallel to the damaged iris zone. And this is the scleral tunnel that I'm making. And then I pass my one needle of the ninoproline, take a peripheral bite, and externalize it through the scleral tunnel. Now the second needle is being passed in the same method through the peripheral, take a bite to the peripheral iris tissue, and then externalize it through the scleral tunnel. Now I will gently pull this suture backwards. Then again, I take another ninoproline suture, do the same method, take a peripheral bite, again externalize it through the scleral tunnel, and finally the last bite adjacent to the initial one, a peripheral bite, and then externalize it through the scleral incision there. You have to be very careful and gentle when you're doing this procedure, because you can further damage the iris, and the iris can really bleed here. So be very gentle. And then once you have these sutures, you can tie both the sutures here, And as I'm tying the suture, you can watch the iris getting stretched. You see the iris is getting stretched, the knot is being buried, and now you can see that we have a relatively round pupil. There you see. This was the day 1 post-operative period. And then after a week's period, you can see the aerodialysis has completely gone and we have a relatively round pupil. So pre-operative, you have this picture, and post-operative a round pupil. So this is important, as the patient will have now less glare. And further on, if you have a very large pupil, then you can further do a pupilloplasty also. So another technique that I'm going to share with you is a modified sewing machine technique. And I would like to just, show an animation so that you can just get clear with the concept, what we are doing here. What we do here is we use a 26 gauge needle, and through the lumen of it, we place a ninoprolene suture. Now we make a scleral tunnel, which is again parallel to the damaged aerodialysis, and then we enter the eye through the keratome. And now, using that 26 gauge needle, we will now pass it and take a peripheral bite of the iris like we did in our initial case, and then externalize it. Now we will withdraw this suture which was there, and then slightly again withdraw it and take a bite and take a loop out of the 26 gauge needle. Again, we do a similar uh, repeat of the same thing, and then again we finally make 3 loops, and then we will take this, withdraw the needle, the ninoprolene, from the lumen of the 26 gauge and pass it through these loops, and then tie the knot. So this, and then the whole thing will get repaired. And I'll show you the case of mine. Now this was a traumatic cataract with aerodialysis, a mature cataract here. So we stained the anterior capsule. We went on to make the capsulorhexis here, and then as you can see, the cataract is pretty soft. So phacoaspiration and then an IA is done. In a similar way, we make a conjunctival peritotomy. Again, do a scleral tunnel 2 millimeters away from the limbus in the aerodialysis area. And now I'm placing the ninoprolene suture through the lumen of a 26 gauge. So I will insert it like a railroad technique and move it forward inside it. And from the opposite end, as you can see here, I will now pull the suture, and I keep pulling it till I let a small tag of the suture in front of the 26 gauge. Now I will place this 26 gauge needle through my paracentesis, take a peripheral bite, engage the iris tissue, again go through the scleral tunnel, externalize my needle, and now I will pull this suture out. See, I'm pull this suture out. Again, now I will slowly withdraw my suture here. I gently withdraw this suture, and now take another bite just adjacent to the initial one, and again externalize it in a similar fashion. Again, I do it at least 3 times, and then I finally withdraw my 26 gauge needle. Here you see, after getting all these 3 loops, I will now gently withdraw my 26 gauge needle and withdraw the needle. There you see the needle of the prolene suture. And now I will pass this needle through the loops here, and tie. And as I'm tying, you can see that the iris is getting stretched and the aerodialysis gets repaired. And then I cut the ends of the suture and bury the knot. This is followed by the insertion of the intraocular lens, and then the removal of the viscoelastic, and I do a cautery of the conjunctiva, and the case is completed. You can see here I have a round pupil there. So the first post-op day, I had a relatively round pupil here. And this is how the case looked. This was the pre-op picture, and this is the post-op picture. So you see the whole aerodialysis gets repaired, And if you have a little, there is little slightly hang back here, but you can do a pupilloplasty also later on to make it further round. So to conclude here, iris repair can be very rewarding both for the patient as well as for the surgeon. And it's important to repair these aerodialysis cases because the patient might complain of a lot of glare, halos, monocular diplopia. So you really need to sit with the patient, understand his problem, and go ahead and explain everything. There are multiple techniques to repair this, and they can be done very successfully. In cases where you have a very large tear, now they have prosthetic devices. They come up with the human optics artificial iris, where you can place this iris on top of the, on the sulcus or underneath the anterior capsulotomy margins, and where you can get a fairly round pupil. So still a lot of research is going on, and you may get some more, wonderful devices in the future. So it's very important to repair these cases to help alleviate the patient's symptoms and enhance cosmesis, as well as give some functional vision to the patient. Thank you.